Welcome to ATCM, the Emergency Medicine channel. Today we have the consultant from Respiratory Medicine, Dr. Asmita ma'am with us. Today I'll be presenting a case of 75-year-old male patient who came to our ER with complaints of hemoptysis since 2 to 3 days. On 10-second assessment, patient airway was patent, there was no secretions, pooling of blood or gurgling. At this point of time, we have kept the patient propped up at an angle of 30 to 45 degree. Coming to the breathing, patient had a respiratory rate of 22 per minute and a saturation of 94% at room air. Air entry was bilaterally equal and patient had coarse crepitations bilaterally. On circulation, patient had a BP of 118/94 mmHg with a pulse rate of 108 per minute. At this point of time, 2 large bore IV cannulas were put. On disability, patient had a GCS of 15 out of 15, pupils equal and reactive to light. On exposure, patient was afebrile and had a GRBS of 123 mg per deciliter. Coming to the adjuncts of the primary survey, we had done a CBC CRP to look for the HB of the patient, and the HB of the patient was 9.5 with a total count of 6.5, platelet count was 1,75,000 and CRP was 261. We had also taken the chest X-ray of the patient, which showed increased bronchoalveolar markings. And then we had taken a VBG, which showed features of respiratory alkalosis. And then we had also taken an ECG, which showed sinus tachycardia. Coming to the sample history, 75-year-old male, known case of old pulmonary TB, who has completed ATT 6 years back, and also a known case of bronchiectasis, presented to our ER with complaints of hemoptysis since 2 to 3 days. Patient had cough since the last 2 to 3 months and it got aggravated since last 2 weeks. Patient had sputum mixed with blood since last 2 days. First day there was hemoptysis of 20 to 30 ml, and on the next day he had hemoptysis of 40 to 60 ml. He was telling that it was about half a cup. There was no diurnal or positional variation. Patient does not have any complaints of fever or night sweats. Patient does not have any complaints of trauma. Allergic history, there is no drug allergy. Medical history, patient is not on any anticoagulants. And last meal was 2 hours prior to our presentation. On general examination, patient was conscious and cooperative. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema. On oral cavity examination, there was no bleeding from the oral cavity. There was no nasal bleeding. Coming to the respiratory system.
Okay. I think we will stop here. So, can you please summarize the history?
Patient is a 75-year-old male who is a known case of old TB and completed ATT 6 years back. Patient is also diagnosed with bronchiectasis, and then patient came to our ER with complaints of chronic cough and hemoptysis since last 3 days.
Okay. So, what do you think can be the reason for hemoptysis?
Patient is already a known case of old TB. It can be a sequelae or reactivation of the TB, or patient is also a known case of bronchiectasis. So, bronchiectasis is also one of the cause of the hemoptysis.
Okay. So, just as a thinking loudly, so if it was a reactivation of tuberculosis, don't you think patient will have some fever or some constitutional symptoms like loss of weight, loss of appetite? However, he didn't have any of that, right? So thought process is like a patient is having bronchiectasis. So was this the one thing which you should have always asked the patient when he comes for the hemoptysis, he or she comes with hemoptysis, is whether this is the first time in his life he had hemoptysis or he had previous episodes similarly. Did you ask the patient like that?
Patient had previously also history of hemoptysis.
When was the last episode? Then the next question will be, when was the last episode of similar illness?
Last episode was 4 or 5 months back. He had similar.
Was it massive? What leaded? How was it treated?
It was conservatively managed.
At home?
No, he came to the hospital, but on medications, he got relieved and he was.
So this is something ongoing, right? So then second is like, this is history part is finished, na? The history, all history is over. So I believe he was having some, was he having any other pathology which was also existing, which can increase, was increased chances of hemoptysis was why was he developing recurrent infection? Because that is what looks like chronic cough and all. So was there any immunocompromised status or anything going
Patient
on?
was a known case of AML, so patient was on chemotherapy.
So that's a very relevant history, isn't it? So when you have a simple case of tuberculosis with bronchiectasis, that itself is sufficient to cause amount of bleeding which he has got. So now the second part of the hemoptysis. So how the first part which you told about the patient when you did A, B, C, D, E. So he is a 75 years old man who came to you with history of no desaturation, not in respiratory distress, but you ask about the gurgling sound. Why?
Because if there is a massive hemoptysis, it can cause pooling of blood in the oral cavity and it can compromise the airway of the patient.
So was like if patient was having gurgling sound, was like what I am trying to say is that that particular thing you wanted to see whether it is inside the airway, the blood or the content or clots are there inside the airway, right?
Yes.
So that was the reason that you asked for it. But there are indirect signs of respiratory distress, like patient will desaturate, patient will be tachypnea, patient will be so most of the times the hemoptysis patient, the time to intervene will be very less, because what will be the internal diameter of trachea? Anybody can say? So what are we dealing with? The airway, correct? So gurgling sound you asked because you wanted to see whether the tracheal lumen was having any inside blood or any content which is still remaining, correct? Then you told BP was fine, 118, 98. 98 I would say high, because with 118 systolic, diastolic of 98 is slightly on a higher side. Was he hypertensive?
Patient is a known case of hypertension, and patient at that time was severely anxious also.
So was he on taking medicine? One of the major reason for hemoptysis is stopping antihypertensive medicine. However, this BP cannot cause, I'm not telling in this particular case, but when you are having a hypertensive patient, I had seen that massive hemoptysis because of hypertension also. So that has to be asked. Then exposure, you asked everything. Then CRP was slight high, 261, significantly high. And chest X-ray was prominent vascular marking. That is what we did, right? No other pathology or no other visible finding was there. Did you see the blood which he was bringing out was in big clots or frank blood or color of the blood? Do you think it is relevant to see what color of blood is coming out?
Yes, it was bright red. In hospital also patient was having hemoptysis.
So is it important to see that?
Yes.
Why?
Because at many times patient can misunderstand, like with hemoptysis and hematemesis patient can.
How do you differentiate hemoptysis from?
Hemoptysis, it will be bright red, brick red color, and hematemesis will be coffee colored in color. Then patient also will be having cough, mostly patients will be having a cough history related to the hemoptysis, whereas in hematemesis patient can have the abdominal symptoms and associated jaundice all patient can develop. Then
The food.
food particles also in hematemesis, there will be food particles associated with the blood.
Yeah, so the history of vomiting associated blood and history of this, and sometimes the coffee colored blood, and it is very important to rule out hemoptysis with hematemesis. Second, which is written in the books, is sometimes because the blood is coming from the air, you might see some bubbles in this, while in hematemesis it will not be there. Coffee colored blood does not matter. Sometimes the patient might be bringing out old blood also. Why the color of blood is important is not only for differentiating hemoptysis from hematemesis, but also to find out whether it is a fresh bleeding or old bleeding, because if it is old, I may not be that much panic, but if it is new blood which is just bringing out in the background of AML will be worrisome. So hemoptysis, hematemesis is differentiating point to see the vital ABCD. Everything is important, and most important is to secure the airway. Coming to the past history part, patient had history of tuberculosis in the past, patient had history of massive hemoptysis. So one or two things which I would like as a pulmonologist to ask my patient was how many times the hemoptysis needed ICU admission, because that patient you may not able to ask, but definitely the relatives are important, and you can go back to relatives and ask what was the largest bout of hemoptysis, how many times he required mechanical ventilation, because that will prime you the amount of bleed which you're going to face, because if he had history of massive hemoptysis in the past, then it is going to happen again. While if the patient was like always managed conservatively and this is a single episode, then there will be a reassurance that you might able to manage with the conservative management. Also the conservative management we will discuss later, but this is relevant that how many times he required mechanical ventilation, was bronchial artery embolization, was there any other intervention done for the procedure, that you should ask. Reactivation of tuberculosis is a very good point. It has to be supported with the constitutional this thing. Bronchiectasis can be sequelae or can be the cause of tuberculosis. Like bronchiectasis is an illness which can be congenital, which has many other reasons. So bronchiectasis per se, I would not say that I would label it as a sequelae of tuberculosis without going into detail of that, because we do not know whether patient had bronchiectasis prior to tuberculosis or after tuberculosis. So bronchiectasis itself can cause, TB itself can cause hemoptysis. So we have two reasons that patient might be having, and chronic infection which he is going with the background of AML, which makes him more prone to. So we are dealing with, as per the history, we are dealing with a case of AML with bilateral bronchiectasis, probably because chest X-ray didn't show, and maybe post TB sequelae he had presently. Now the second question will be, how will you label this hemoptysis? Is it mild, moderate or severe? Does it matter?
Yes, usually coming to the ER point of view, we divide it as life-threatening hemoptysis or non-life-threatening hemoptysis. Life-threatening hemoptysis is when it compromises the airway, or we have a blood gas compensation, or we have a large hemodynamical instability.
So I would rather like to see the values of VBG rather than it was normal, because I do not consider anything normal until unless I know the values. So I would like to know what was the pH, what was the PCO2, what was HCO3.
pH was 7.5 and PCO2 was 23 with a bicarbonate of 20.
And PO2?
PO2 was normal, ma'am. No, hypoxia was not there for the patient.
So this is VBG or ABG?
The VBG was taken.
This is ABG now, because it is 23 PCO2. In VBG, PCO2 23 is quite unlikely, right? And 7.5 pH. So the important message is, it doesn't matter you getting ABG or VBG, pH is always almost same. But by looking at pH, you can deal with what pathology you are doing. So this is alkalosis. So patient was tachypneic. He's washing out PCO2 and he was very anxious, as she rightly said that at the time. So when we deal with management, this point is very important, that how to manage some of the problems. So on examination, you told patient was respiratory rate was 20, right?
22 per minute.
22 per minute, and his other signs, there were no signs of any other general examination. Okay, now you can go ahead to respiratory system.
On respiratory system examination, on inspection, trachea was central. There was adequate chest raise, no scars or discharging sinus was present. On palpation, trachea is central. There is no local rise of temperature. There is no tenderness, and vocal fremitus was equal in all areas. Coming to the percussion, vocal resonance equal in all areas equally resonant on percussion. Coming on to auscultation, vocal resonance is equal in all areas, air entry was bilaterally equal, and there was bilateral coarse crepitations. On CVS examination, S1, S2 was heard. Per abdomen, it was soft and non-tender, and CNS examination, there was no focal neurological deficits.
Abdominal.
Per abdomen, it was soft and non-tender.
No hepatomegaly, no splenomegaly. Okay. So what do you want to add upon on your diagnosis, which we made from the history, or you stick to the things which we said? Can you please give whatever is your final conclusion? What are we dealing with if you are asked to present the case?
Patient had a positive finding of bilateral coarse crepitations. Air entry was bilaterally equal also.
So what does it matter? Like if bilateral air entry is equal, what does it suggest?
There is no compromising of airway Both lungs are getting.
In which way the airway can get compromised in a case of hemoptysis?
There can be a spillage of the blood from the affected
Very
lung to
good.
the normal lung.
Yeah.
So
No, here bilateral crepitation. So how will you differentiate which is affected lung and which is normal lung? We do not know, right? We do not know any idea. But if there was air entry diminished on one side, why would you think that it is a spillage of blood? I would rather think about the patient has aspirated the blood which has gone on the same side. First, the same side will be affected, then it will go on the opposite side, right? So do not start thinking on the opposite direction from the beginning, because we do not know. First of all, patient has bilateral crepitation, so we do not know which lung is the pathological. We do not know which side the bleeding happening, right? Can you make out? No. Correct? How can you make out? If I ask that, okay, now I want to make out which is the bleeding side. Which are the ways? 1, 2, 3. That you will make out that, okay, this. What should you look for?
If air entry is reduced in one particular side, then.
But it is not now.
No.
This patient. Is there any other way to make out? Past history. Go to the past history and find out. There are, if patient is our own follow-up or patient is old follow-up of some other hospital, go through the records. If the other doctors have done previous bronchoscopies or previous CT scan or previous bronchial artery embolization, they would have documented. Sometimes patient relatives will be telling that right side or left side. So then you can go to the imaging also. If there is localized aspergilloma or localized cavity on one particular side and other side it is not there. So no, definitely we cannot say just by looking at the patient and just by doing the clinical examination of the patient, nobody can say that which side is bleeding. You need further support either in the form of imaging or in the form of bronchoscopy or in the form of some past records. Otherwise we cannot. Bronchoscopy in such a patient you may not able to see, because if it is a pool of blood, patient is bringing out 40 to 60 ml blood in each bout of cough, then I would not suggest that it is a brighter idea to do and jump and do bronchoscopy right away. What should you do next if this is your case in ER?
We could go for a CT. If the patient is stable, then we could go for
patient is with you now. You saw the patient. Do you think patient is stable? What should be immediately done? Patient is anxious, patient is coughing out blood, patient is like extraphoretic because of he's seeing his own blood.
We could give some anxiolytics to the patient. Injection morphine subcutaneously can be given. Then cough suppressants can be given.
Yeah, you have to be careful because you are dealing with a chronic bronchiectasis with old pulmonary tuberculosis, and tuberculosis is one of the commonest reason of COPD, or it is called tuberculosis associated pulmonary chronic pulmonary disease. But she has got VBG of the patient which shows PCO2 is 23 and pH is alkaline. So I would not be very much worried about PCO2 retention, and I would liberally give diazepam or some other drugs which will make my patient stable. The benefit of diazepam is not only it will make my patient slightly decreased anxiety, as well as it might give some sedation effect which will indirectly decrease the amount of cough. The second thing is we have to, as soon as the patient is sedated, what you should do is definitely imaging to locate the amount of bleeding is what and where. Mostly, if possible, what kind of CT you would like to do?
MDCT we can prefer.
We have to do a contrast CT because we need to find out locate the blood vessel. Which is the problem? Is it pulmonary circulation or is it a bronchial circulation which causes massive hemoptysis?
Mostly 90% it is bronchial circulation that is causing massive hemoptysis.
Yeah, because pulmonary circulation is a low pressure, low resistance circulation. It won't cause massive hemoptysis. Bronchial circulation is a high pressure, high volume. It causes massive hemoptysis. How can you locate which blood vessels are bleeding? What is the method? By doing
contrast CT, we can
CT pulmonary angiogram. So MDCT will not be sufficient. You have to do CT pulmonary angiogram, and we can very well locate is there any bleeding vessels or feeders. That is what is called feeders. Means if you have a cavity and then particularly you might develop so many collaterals supplying that particular cavity. That is called feeders vessels, and if you have to locate then you have to give a contrast to find those out, and interventional radiologists can do that job very well. So you have to have good connections or good clinical correlation between you and radiology team, so that it's a multidisciplinary approach. One person cannot handle everything, so this has to be coordinated. You have to be over phone connecting with them. What are the other things which you can give to this patient? You have arranged for CT scan. The CT scan is being done. Meanwhile, what will you do?
Initially, we'll give an anxiolytic so that to calm the patient.
Yep.
Then cough suppressants can be given so that it suppresses the cough. Then Tranexa nebulizations can be given. 500 mg Tranexa.
Do you think patient was in sepsis?
Yes, patient is on sepsis.
Do something about that.
No, IV antibiotics also. First dose of IV antibiotic can be given for the patient.
IV fluids, either colloids, because he's losing blood, right? Even though he's 9 hemoglobin. If whether the patient's what is the status of patient? Because sometimes what happens is when the patient comes to you, your hemoglobin, well, the patient's hemoglobin is 9. Now you start treatment for the patient, you hydrate the patient, you make him better, and suddenly the hemoglobin will fall to 7. I get those kind of calls that, oh, he's still actively bleeding. What do you think? What happened?
Initially, it was due to hemoconcentration.
Yeah, he was dehydrated, and then you corrected all those dehydration. So it's not because of active bleeding, it is because of the treatment which we gave. So just because of 1 or 2 values, you should not jump and start correcting and all those things. So hemoconcentration happens in particularly those patients who are so anxious, not eating anything, all those things. So it's not, your management is not working. You should go by other parameters. Which are the other? So when patient has got bleeding, what should go wrong? If active bleeding is still going on, how will you identify? Maybe patient is not coughing out, you sedated the patient, but I want to know, I am your consultant, how is that patient? How will you decide? Patient is sedated now, patient is not coughing out, whether the active bleeding is going on, because sometimes the blood vessel which is bleeding is going on. How will you, which are the bedside parameters by which you will see that okay, bleeding is not going on, or bleeding.
You can look for any tachypnea or hypotension patient developing.
Yes, that's very good point, that if your patient is quiet, if patient is bleeding, then even the patient is quiet, there will be hypotension, there will be decreased urine output, that it will be tachycardia, even though not tachypnea, because tachycardia cannot be controlled just by sedation. Okay, so there are indirect signs, so you should go by all other signs of also, which will suggest you whether the bleeding is ongoing or not. And definitely you have to check CBC and hematocrit every 4 hourly in a patient of massive hemoptysis. So do you know any other interventional radiology procedures by which you can control the bleeding, which should be done in emergency? By doing after CTPA, what will you do? You have shifted, CTPA results are out, you identified some feeders.
Bronchial artery embolization.
What is bronchial artery embolization?
Most commonly used agent for bronchial artery embolization is polyvinyl alcohol. Using that, otherwise
gel form are also used. It's not polyvinyl alcohol was earlier used. Now they have got spigots and they've got many things. It's all advanced moving. It's a dynamic branch in which the things change. The basic mechanism or the basic principle doesn't change. We do not care about what particles are being used, because that is a radiologist's job. You are the consultant in charge and you have to explain the patient that, okay, I may do this procedure. What will you explain? Bronchial artery embolization is being done for the patient. You are emergency in charge, you're going to shift the patient, but as a duty, I'm sure interventional radiologist also will explain, but as a consultant in charge, if you are asked to explain about the procedure, 1, in your own words, 2, complications, 3, what are the precautions which you're going to take? What will you tell?
We have to initially get the consent of the bystander for the procedure, tell about the sedation we give for the procedure, then the process we'll be injecting the material and trying to stop the bleeding. After the CTPA we are doing means we'll tell that we have got the location of the bleeder, so we are going to give us agent and then trying to stop that bleeding site. So in the process of that there can be complications like rebleeding can happen. Even if we stop the bleeding also, there is a chance of rebleeding within 1 to 2 days or maybe later also. That can be also explained. Then
complications. So one of the complication is we cannot guarantee that the bleeding will stop. Recurrence of bleeding is one of the most common complications, because as we can understand that there might be one or two or more than two blood vessels, and there is a limited amount of blood vessels which can be blocked by putting these particles. One of the major complications which radiologist will definitely explain will be if this particular branches of bronchial artery is internal mammary artery. Internal mammary gives origin to the anterior spinal artery, and anterior spinal artery may give origin to the ophthalmic artery. Okay, so if you go to the anatomical course of the spinal artery and then going, if the internal mammary, spinal, and going to ophthalmic, then there are major two complications. If spinal artery is paraplegia, and ophthalmic artery will cause blindness. Now mind you, those particular complications are irreversible. So when you are doing a procedure which might cause a patient blindness or paraplegia, you make sure that that particular risk of bleeding is going to cause death. So when I am explaining my patient about bronchial artery embolization, patient might not be relatives. So what I put forward is my patient is almost on, if I do not do this procedure, it is life threatening for him. So I do not care whether my patient is going to become blind or paraplegia if I am going to save his life. So if we put that much, and you have to ask yourself also that is it that much necessary that if you do not do this procedure, it will be impending death. So most of the times the bronchial artery embolization is a life-saving procedure which can be done when your patient is already on mechanical ventilation and there is active bleeding, which we already discussed how we find out, and we have located the vessels by doing CT pulmonary, and there is only one localized bleed, we go ahead, because the success rate is only around 60%, the 40% cases come back. That is why I asked that whether the patient had bronchial artery embolization done previously or not. So those kind of, we have seen cases when we do almost 2-3 yearly again. These are the cases which are not fit for surgery. As I said that bilateral etiology is there, bilateral pathology is there, we cannot do surgery. So these are the cases where we have no other option than doing bronchial artery embolization. The complications are recurrence. Then we might be blocking the blood vessel which might be supplying this or this branches, can cause paraplegia or can cause blindness, and those things will be irreversible. But presently my main focus is to save life of my patient, and I may not care. We might see if it is a chance or it is a risk which I would like to take, but it has to be put it in black and white, because this has been the major complication. The third is infection. Infection can happen, and the fourth is chest pain. Now tell me why chest pain can happen. That is the very commonest complication is hemoptysis, recurrence, and chest pain. So what do you think? What happened? Why should the patient have severe chest pain? You have to give morphine. The reason is you are doing a blocking of the blood vessel which will cause infarct, right? Because you are stopping that blood supply. What happens if the patient develops infarct? Pulmonary embolism, infarct, chest pain, correct? So that particular part we are doing iatrogenic infarct, and that will be causing chest pain. So chest pain is one of the major complications which has to be handled, and we have to immobilize the limb for at least 24 to 48 hours, and then only we mobilize the thing. So that is one of the thing which we can do for our patient when patient are really very sick. The second thing is after stabilization, if you want to go inside, if you are doing, you have a team of interventional pulmonology available and you want to do some one lung is only bleeding, or if only one lung is a problem, and if you want to save your life, what can you do other than that?
Single lung ventilation can be
Single
done
lung
for the
ventilation,
patient.
yeah, and then you can identify the blood vessel which is causing the bleeding, or the side of lung which is the culprit. What can you do through that? If bronchoscopy, if you are going to do, then
we can give topical vasoconstrictors.
Yes.
And then block the bleeding can be done. That can be
Yeah.
done. Otherwise, balloon tamponades can be
Yes,
tried for
balloon
the
tamponade.
patient.
Bronchoscopically, you can identify the segment or the lobe, and you can put Fogarty's or balloon and just wedge that particular segment and inflate the balloon and just leave it there and come out. So it will definitely cause tamponade effect, and if patient's bleeding parameters are normal. The problem arises when you are dealing with something like AML or CLD or some bleeding diathesis where we cannot control the bleeding, and then when that patient is already on anticoagulants or on some agents which prevent blood from clotting. If the natural clotting mechanism is existing, the tamponade effect will be sufficient. Over a period of time, blood can stop. Now coming to what are the how do you identify, like I don't think that is important for you people, but coarse crepitations of bronchiectasis and crepitations for congestive cardiac failure. So do you think this patient was having cardiac failure, or why crepitation, bilateral crepitation? What will be the differentiating features between cardiac failure crepitations and bronchiectasis crepitations?
In bronchiectasis, it will be coarse crepitations will be heard bilaterally. In cardiac, in patient didn't have any other features of cardiac failure, like bilateral pedal edema was not there, elevated JVP was not there, ascites also was not there for the patient. In
Yeah, that's the characteristic of crepitations in cardiac failure will be bilateral basal fine crepitations, while coarse crepitations are, it's all rills kind of, rather than crepitation it is rills. It is having water gurgling sound will be coming from the airway. So that is the main differentiating point. It can be even pneumonia crepitations, we never know, right? So hemoptysis management, by bronchoscopic management of hemoptysis, you can do bronchial artery embolization, or you might do surgical management. When can you do surgery?
when we try for bronchial artery embolization and it becomes a failure, when there is a recurrence of bleeding even after doing the embolization, in cases of trauma.
So this particular point, I would like to say that bronchial artery embolization is not a first choice for few patients. We do it. It can be a bridging between surgery and this. So bronchial artery embolization cannot be done, or bronchial artery embolization failure is not an indication for surgery. There are different group of patients. The prerequisite is localized disease. If patient's disease is localized, then only you can do surgery. If my patient has got upper lobe, middle lobe, lower lobe, left upper lower lobe bronchiectasis, which lobe you will remove, right? So it is not about bronchial artery embolization does not come in a picture. There are specific indications for surgery, and the surgery indications are it has to be localized disease, the prerequisite. Then recurrence, infection, ICU admission, this, that, and failure of, like if localized disease, I might do bronchial artery embolization, and if it doesn't work, then it comes. But the prerequisite is it has to be localized disease. For bilateral diseases, we cannot do. Why? Why can't you do for bilateral disease? Which lobe you will remove, how much you will remove, and how it prevent, because when it is bilateral bronchiectasis, most of the times it is congenital. So you cannot change the pathology. It might be genetic disease. So if it was acquired because of some tuberculosis or because of some recurrent pneumonia, you might remove and change the illness. But when it is bilateral bronchiectasis, the primary pathology or primary etiology behind the bronchiectasis is different. By doing or removing surgery, it won't change. So bilateral is not an indication. Second, fitness will come as an issue because those patients may not be fit for surgery. Now, do you have any idea about which patient will be fit for surgery? How do you decide fitness, or it doesn't come in your field? It's okay if it doesn't come. So lobectomy is 1.5 liter of FEV1 and pneumonectomy is 2 liters of FEV1. Then only we can decide for fitness. Now, how will you decide discharge criteria for the patient?
If any massive hemoptysis is not there, we can admit the patient and observe the patient in our ICU, and then if the patient is asymptomatic after the initial management with the medications, then patient can be discharged on the third or fourth day if there is no hemoptysis.
Yeah, and you have to rule out the 260 CRP and all. We have to
Infection
find out
was
the
there.
reason, right? So because this patient has got a chronic cough, this patient has 260 CRP. Patient has been. What will be the commonest organism which you will be dealing with? What antibiotic you will start empirically? Patient has bronchiectasis, recurrent infection.
Most commonly, organism can be Klebsiella in bronchiectasis.
I would say Pseudomonas.
Pseudomonas also.
Pseudomonas, not also. Pseudomonas is the organism which happens in bronchiectasis, and there are treatments of chronic colonizers also because it will come recurrent. So this patient might have, so your antibiotic of choice or drug of choice should be covering Pseudomonas, and mostly you have to give dual coverage because he has come recurrent. And you have to have a long term plan, because if it is ongoing last 4 months before and now also, so there will be chronic colonizer, so you have to give some prophylactic antibiotics to prevent it. So before discharge we have to decide about preventive plans, what is the treatment plan, and you have to if you are handing over the case to a treating consultant team, then also you have to tell them that this is what has been done and this is what we expect. So treatment plan has to be immediate plan as well as long term management plan, because patient has chronic illness, it is going on for a long time. So, is there any other point which you people discuss in ER cases? So there are immediate care and there is long term management and intubation. If intubation, so not necessary all the patient requires single lung intubation and all. We do not have to complicate the things, simple things first. So until unless you have a CT scan which suggests that okay, the one lung is really compromised and the other lung is relatively okay, we do not have to, because the double lumen tube is not everybody's ball game. You have to be really experienced to put a double lumen tube, and you might do it. It's very panicky situation, and until unless you are sure of you will go inside and put it correctly, I would rather suggest that put a single lumen tube and put a lateral position. That also will work equally. By the time you can get help for putting double lumen tube, it's not always necessary to put a double lumen tube. Second thing is bronchoscopy. As an interventional pulmonologist, I would rather say that there are controversies about the guidelines. In bronchology, guidelines also does not suggest that you should jump and do bronchoscopy right away. You have to, the patient stabilization or patient airway, breathing and circulation is far more important than doing and localizing where it's at least the bleeding, until unless the patient is stable. And second, I would put my bronchoscope in only if I have a support of rigid theme, I have anesthetic support available, and I would do bronchoscopy as a therapeutic bronchoscopy rather than diagnostic bronchoscopy in the case of hemoptysis, because the role of diagnosis is very less. However, we have seen cases in which the bronchoscopy will yield you a bleeding mass or tumor, but that particular thing will be definitely picked up on CT scan. So until unless CT scan is done, I would not put bronchoscopy first, and second, bronchoscopy will be done as a therapeutic measure rather than diagnostic measure. Definitely not to locate the blood vessel or feeders or anything, because if the patient has an amount of blood, now coming to internal diameter of the trachea, the internal diameter of trachea will be around 1 to 6 to 7 centimeter of that. So your tube, whatever you are putting, the blood amount which is coming, which will cause occlusion of trachea, will be massive. It is which causes death. What causes death in case of hemoptysis? Is it asphyxia or asphyxia rather than extinguishing? Because mostly the hypotension which is caused by bleeding is not amounting or will not be causing the death. We are dealing when the large amount of 500 ml. So the internal diameter of the trachea is around 7 to 8 centimeter. If 500 ml of blood, and with a normal clotting, if either the clots causes hypoxia or it causes occlusion of the trachea. That is the main reason, and that is why the airway is the most important. However, you can manage, you can ask for the blood transfusion to be arranged and other things can be done, but that is your second priority in such cases. Airway is the main priority. Secure the airway and then your half job is done in case of massive hemoptysis. And then the third most important thing in massive hemoptysis will be to get the imaging done as soon as possible and then locate the blood vessel and do bronchial artery embolization, because you have to buy the time irrespective of whether the patient is candidate for surgery or not a candidate of surgery. So these three things which we do usually, and most of the times the conservative management like ethamsilate and Trenexa causes significant control of bleeding in most of the cases. As I told, the key is what is the underlying factor and how is the clotting parameter. So PT and APTT are the most important blood results which you have to find out, because if the patient's clotting parameters are normal, even tamponade and even your medicines will work. While if there is a massive bleed from bronchial artery, it may not be controlled and patient will require intubation. Aspergilloma bleeds very badly and that needs surgery because no antifungal treatment will work. Here the main reason is infection which is ongoing, and better control of infection will give him relief. The infection main cause is maybe AML is the culprit and that needs treatment, and because of the treatment or because of the disease itself, he is immunocompromised and he is developing recurrent infection. Prophylactic antibiotics are must, and that has to be given to the patient. Okay, I think that will conclude the case. Thank you so much for participating.